All right, we're going to go ahead and get started. Um, Covering PHTLS tonight, very similar to AMLS when it comes to like our assessment. Most of these are pretty much scenarios. They're a little bit longer in length, I would say scenario wise when it comes to like vital signs and the information it gives you. But it's very similar to AMLS, except now we're dealing with trauma situations. We do know that there are times where trauma can occur because it's secondary to a medical issue, such as somebody that their blood sugar drops or they have a heart attack or they have a difficulty breathing and then they end up getting into a car accident. That's absolutely plausible, but this actually focuses more on trauma than the medical side of it, and it's really the gold standard for EMS agencies across the nation. It's something that every program generally offers in the beginning. It's not mandated by all services, but I'd kind of warn you, I would keep up on it, go through a renewal class, whatever you do, just to obtain or maintain this certification. Now, the two different graphs here is really just showing the different aspects of trauma and the different aspects of what can occur and kind of what is the most common cause of trauma in our society. And you can look at the age ranges. So when you look at like falls, it stays pretty steady, but starts to kind of uptick towards our older years, our elderly population. And the graph on the right side is just really showing a continuum, as you see. Look at motor vehicle traffic collisions. It's generally in our younger populations. Poisonings, again, younger population gets less as we get older. But these are going to be the primary causes of traumatic injuries in the United States. And this was ran through 2015. It's provided by Center for Disease Control. But again, just up until 2015, I'm guessing numbers, if we were to look in the last 9 years, that we would see that trend actually continue. We wouldn't see really any change of it because it is pretty prevalent or thing that we see the most common. MVCs is honestly going to be the most common in our early years when we account for deaths and traumatic injuries or traumatic arrests. Trauma also has different impacts, not just the medical impact, but looking at economic impact. So somebody being hospitalized for a period of time, what impact does that take on them? What impact does that take on their family? And also the impact on us as pre-hospital providers, not just economic, but in a mental health standpoint, as well as, when we have to respond to these emergencies, is it something that maybe might affect us later on? The ultimate goal with PHTLS is ultimately to reduce mortality and injury from trauma. We're trying to prolong or treat as much as we can on scene before loading them up and transporting them. And transport can differ from area to area, whether it's a ground transport, maybe we're looking at fixed wing, maybe we're looking at rotor wing, such as a helicopter, which we would see primarily in this area. But really, it gives us the tools and a solid foundation to kind of move forward with our care and our assessment. So if you look at goals, this is just like a circular algorithm they have from preparation to return to service. So making sure that we're ready, trained to be able to respond to these calls, that we do respond, we manage them effectively, that we give our patients the ultimate care that they deserve, that we are doing a good handoff report. So that way the hospital or whoever we're handing off to, a helicopter, whatever it might be, gets all the information they need to continue to treat this patient. And documentation, I think I've said this to you guys before, in my opinion, is just as important as patient care itself. So make sure you're documenting accordingly. Very similar to AMLS, the approach is X, A, B, C, D, E. We know X stands for like exsanguination or massive amounts of bleeding. PHTLS also is something that kind of was used and is still kind of used in the combat setting. They've kind of tweaked it a little bit and created their own certifications, but this was, again, really the gold standard in those situations. And it's something that is still followed pretty closely. But above all else, we focus on that life-threatening bleeding, and then we start to work down our primary assessment. So this was actually developed. There's a course called ATLS, which is Advanced Trauma Life Support, which is pretty much gone through by like physicians or higher level practitioners that work in hospitals. That started, I want to say, early 80s, late 70s. PHTLS was actually drafted, I think, in the mid 80s, if I remember right, by somebody that said there is a need for it in the pre-hospital setting, not just the hospital setting, because what was happening was we didn't know how to treat these patients. And actually, it was after a plane crash had occurred, in which the pilot was a surgeon. He had his wife and 4 children, and that's really where this started to take off. And as you can see, it's something that's practiced almost worldwide. Principle, when you see the word principle, they're just looking at what needs to be done for the patient based off of the patient assessment versus preference, which is, okay, how are we going to go about accomplishing this? There's multiple routes to accomplish something, but just what's the best one for this patient at the time, based off what you have at the scene, based off of how severe the patient is, what you have as far as resources. Is there an ALS ambulance available? Is it a BLS ambulance? Do you have the availability to call for a helicopter if need be, or do you have one close enough? Weather also is going to play a role in this as to how quickly we're transporting their patients or how quickly we're loading them up. That's also going to play an impact into how our patients are being managed. We look at different phases when it comes to trauma care. So we have like the pre-event, event, and post-event. Pre-event, it focuses on injury prevention. Things such as not texting and driving, making sure that people are wearing their seatbelt. It's prevention efforts that have really tried to curb the rising trend in traumatic injuries and traumatic deaths. The event phase is just as you would see, it's actions taken during the phase of trauma or when the accident occurs to minimize injuries. Another one that you would see, such as event phase, that could play an impact. Seatbelts is one. Airbags is another one. So when the event occurs, what is something that could prevent mortality and prevent further injuries? Motorcycle helmets is another common one. And then we have post-event. Once the event has occurred, what are we focusing on primarily? And in the recent years, in our civilian population, schools, businesses, they've really focused on stop the bleed courses, which is of utmost importance in my opinion, especially when we look at events that have happened at schools recently, teaching children and teachers and just really anybody on what they can do to minimize loss of life. Stop the Bleed is really nothing more than a public awareness campaign. I mean, it's taught by different levels, hospitals, pre-hospital. It's really just to increase knowledge about hemorrhage control. You've probably heard of the golden hour. It's really that hour that we have from when the injury occurs to them arriving at definitive care. It's not from you arriving at the patient, it's from when the injury occurs to when they arrive at definitive care. And definitive care is ultimately going to be like a level 1 trauma center or somewhere that they can receive surgery if possible. So if it takes you 10 minutes to get to the scene, you only have 50 minutes left of that golden hour. Now, my opinion is that the golden hour is extended as we treat our patients. The golden hour is if, in my opinion, the patient was left untreated. They have that hours is when we really want to get them to the hospital. But if we're providing good treatment and we're able to stabilize our patients, to me, that kind of prolongs the hour. We kind of put a pause on the clock, if you will. But these are the instances where we are spending as little time on scene as possible. We're doing our quick assessments. We're looking at a quick, not even detailed physical exam, trying to figure out what's going on with our patient. We're loading them up. And if we can do a secondary one, or we just pass the information off to another agency that's transporting them. This isn't the time we want to sit and ask about, what allergies or medications. This might be just focusing on the injury itself and not so much on the secondary assessment. Please make sure if you're transporting a trauma patient that you notify the accepting hospital, or if somebody's tearing with you, let them know what the injuries are prior to you arriving there. That way they can, if they need to have orthopedic surgeons on standby, if they need to have blood on standby, that's really going to dictate what resources are there when you arrive, or what resources additionally need to come to you. So to wrap up this one, we should be looking at how and why we do everything. When we talk about treatment, we talk about our protocols. There's reasons or principles as to why we treat them. Now, preferences, we can treat them a little bit differently just based off our protocols or based off of the situation that we have at the scene. Information constantly changes. Our protocols are constantly being updated. Information is constantly being updated in PHTLS, or is constantly being updated in ATLS, or advanced trauma life support. It also, as a paramedic and even an EMT, anybody that works in pre-hospital care, or anybody that works in healthcare at all, we have to be able to adapt to change, because change is it's looming all the time. There's new studies that come out. There's new things that we can do to prevent further injuries. There's maybe a new form of quick clot. Maybe there's, some new tourniquet that's came out, or some new airway device. We have to kind of be willing and open to those changes. Otherwise, we kind of get left in the past. Getting a good picture of what you're responding to, and again, this kind of goes back to our differential diagnosis, is coming up with different possibilities once you arrive at the scene. And that XABCDE is something that we use once we arrive there. Once we initially get eyes on the patient, we're identifying, is there potential for external bleeding? Is there airway compromise? Are they breathing appropriately? Are there any circulation concerns, such as, is the patient potentially in shock? Do they have any disabilities or neurologic dysfunctions? And then are there any injuries that are hidden and we really need to expose them, which is our E. GCS, and I think I told you guys, was originally developed for trauma patients. It was not meant for medical patients like we use it for all the time. We always say somebody's a GCS of 15, or we'll say they're a GCS of 3. Those are the most two commonly used numbers, because people don't really understand GCS, or they don't take the time to memorize what it is, or again, they don't have that chart plastered on the inside of their ambulance. So understanding why we use GCS, and it's really just another assessment tool. It's kind of like alert, verbal, painful, unresponsive. It's something that we can just use as a communication to tell the accepting facility or the tiering agency, this is the mental state of the patient. So thinking of scene size up, thinking of you're responding to a call, what are some things that you have to think of on the way to the call? You're dispatched to a small industrial site for a person trapped in a machine. Patient is a 34-year-old male, right leg is caught in some type of machine, not sure what it is yet. Your ambulance is dispatched along with fire apparatus for extrication. You have a small hospital 15 minutes away by ground, or you have a level 1, which is 45 minutes by ground, or 10 minutes by air. But the helicopter is 25 minutes away from you. So just some things you have to take into account, especially if you have a helicopter that can respond to you. That should always be in the back of your mind. Is that helicopter there? How long is it going to take them to get here? How long is it going to take to load the patient up? Helicopters go a lot faster than some people think. They can roughly go 50 miles in 15 minutes. I mean, if they're really moving. So it kind of just depends on what you have and what you think you need. And if you think you need the helicopter, I would start them early to your scene or a place you can land them, because worst comes to worst, you just disregard them. Knowing flight medics, they say that, okay, the worst case scenario is they get to go up in a helicopter and fly around for a little bit. It does not bother them at all. They'd rather be ahead than actually behind. So knowing this is an industrial site, what are some things that you would potentially be concerned about? Or things that jump out at you?
Is there any bleeding? What type of equipment?
What
making sure the equipment isn't on electrified or anything like that.
Okay.
Lockout, tag out.
Lockout, tag out. Has that been performed? Is another one. Is the machine currently operating? How is our patient presenting? Is there concern for we're going to come into contact with something? Is there potentially an associated spill? What other environmental concerns do we have, such as fumes, noise? Are there trip hazards? Is this a confined space? Is the machinery ultimately safe and stable for us to approach? So fire apparatus arrives before you. The male has been removed from machinery and is sitting against a wall. They report to you that the patient's right leg was pulled into exposed machinery up to the knee. No associated fall or any other injury. Again, you're not there yet. We're responding to it. What are some concerns now? Pulled up to the knee into a machine.
Hemorrhage, bleeding.
Okay, bleeding. A big one for me, what type of machine is this? Is it something that, compresses? Is it something that rolls? Because that's going to dictate my injury. You arrive, the patient appears alert, but is pale and diaphoretic. Okay, so maybe we're dealing with a patient that's potentially in shock, depending on how much blood has been lost. Right lower leg is rapid blood-soaked dressings. Blood is dripping. There's a blood trail from the machine to a pool of blood beside him. This is what you see when you unwrap that cloth. So just based off of that and based off of how it looks, I'm going to guess this was not any sort of chopping or any sort of press. I'm guessing this was pretty violent. What are our concerns with this, knowing it's an extremity and knowing that there's potential for blood pooling?
Arterial.
Okay, is
Bleed.
there an artery involved? Is there arterial bleeding? I'm going to guess just based off the injury, yes. Now, C-spine, is that indicated right now?
I would say no.
Okay. Do you have the resources you need between you and a fire truck to manage this? Or would you want anything additional?
Helicopter.
By all means, get a helicopter started. The second I heard somebody trapped in a machine, I'm probably starting a helicopter at that point. Now, what is the difference between capillary bleeding and arterial bleeding? And how do we know if each is controlled, and how do we control each? Capillary venous is pretty slow. It's not as bright red in color. This is when we get blood that's just oozing out or a small amount of dripping. Generally, we can control that with direct pressure. We can use gauze. We can tape it up. We can use Coban. Even though there's some deep lacerations, they generally can be controlled with direct pressure or, again, bandaging. As opposed to, we get to like arterial bleeding, which ultimately, there's two different courses we can take here. If it is an extremity, we can look at tourniquet placement. If it is anywhere besides that, which was what we call a junctional area, we can pack the wound. That's what quick clot is for. So extremities, and then you have junctions. Junctions are where extremities meet. It could be abdomen, it could be armpit, it could be neck. That is ultimately where we cannot place a tourniquet. They are very difficult to control because it is a massive amount of blood that is squirting out with each contraction of the heart. It's characterized by that bright red bleeding, spurting blood. Ultimately, if left untreated, these patients have right around 3 minutes, if not less, before they bleed out. This video, or that picture that you see there, was actually the guy had taken a skate to the neck. I want to say his name was Clint Malarchuk, if I'm not mistaken. He did survive because they were able to rush out there, and their trainer or doctor, whoever's there, was able to literally just apply direct pressure until they could get him to where they were able to perform surgery. If you've never seen that video, you can look it up on YouTube. It's pretty impressive. So we notice right off the bat, uncontrolled severe bleeding at the right leg. It is controlled with a tourniquet. Once the bleeding is controlled, then our assessment can continue. Airway is patent, patient is breathing slow. We provide supplemental oxygen. Sure, skin is pale and moist. He has a rapid radial pulse. What does a rapid pulse tell you?
Compensating.
He's potentially compensating, right? Heart rate increases due to blood loss. And that's kind of what we see with the skin being pale and moist. Patient is a GCS of 15, so he's actually mentating just fine, which tells me that pressure is, he's compensating enough. to provide oxygen and blood to his vital organs. And then exposure besides the leg. Are there any other injuries? Obviously, in that leg, we're going to have an absence of motor function, sensation, and pulse distal to the injury. But that doesn't mean we can't assess above the injury as well. Now, if you place one tourniquet and one tourniquet isn't enough, place a second one. Tourniquet placement generally, and I can't remember if they say it here or not, it might say 1 to 2 inches above the site. What I'll tell you is, in real life, place that sucker as high as it'll go on the extremity and as tight as it'll go. It's going to be painful, and make sure you tell people that. But compared to what the pain they're dealing with there, it's probably nothing. So potential life threats, and how do we treat them? What do you guys think?
Loss of blood.
Okay, hypovolemia for one.
Need to start 2 large bore IVs and start getting a little bit of fluid into them, and then when they get to the hospital, possibly some packed red.
Okay, so we're looking at stopping the bleeding, and then we're looking at providing fluid resuscitation, not just a saline, but possibly blood. And that's something we should take into consideration as well, because guess what? Helicopters carry blood. They have the universal donor. Some of them have packed red blood cells, but ultimately, this guy, would you transport him to that level 1, or would you take him to that little small hospital?
Level 1.
Absolutely. Unless that small hospital, you need blood or something to help stabilize him, or the helicopter's 25 minutes away, take him to that small hospital first to where maybe they can stabilize him, and then they can pick him up from there. There's nothing wrong with that.
Would this be a good one for TXA?
We'll get to that, but potentially. But here's my thing with TXA is, if it's controlled with a tourniquet or by other means, I'm not quick to jump to TXA, just because I don't know if there's any. In this instance, it probably wouldn't be bad, but if there was concern about like internal injuries, that's where we more look at TXA. Now, if the patient you've addressed the bleeding, if the patient had airway or respiratory concerns, how would you initially manage that patient, and what could that potentially turn into if that's not working?
LPA and PA bagging him, assisting him, maybe intubate.
Okay, start as simple as possible. We look at basic adjuncts, we assist with ventilations if need be, and then if things are still going south, yeah, we look at the more aggressive treatment if need be. We mentioned getting a helicopter, transporting this guy to the level 1. When it comes to the secondary survey, asking about that medical history, asking about medications, allergies. The only thing that I'm going to ask quickly is probably allergies, if I'm giving any sort of pain medication or any sort of med. But aside from that, I don't care about the other stuff. I'll be honest, in these situations, I really don't. You can go down your sample, but ultimately, I'm addressing what's in front of me right now. Primary survey completed, life threats managed, patient transported via helicopter to level 1, admitted for surgical repair. They're probably going to amputate above that, just right above the knee. Patient discharged 1 week later to rehab unit after an above knee amputation of the right leg. That, unfortunately, with how severe it was, there was no chance in reattaching that. What do we know about mass casualty situations? Are they different from us responding to normal calls?
Yes.
What is technically classified a mass casualty incident?
A mass casualty.
Resources are exhausted.
Okay. When all of our local resources or everything that we have is overrun, we can technically classify it as a mass casualty. So depending on the area, that could be 5 patients, that could be 7, that could be 9. It just really depends on the resources that you have. For adults, we use start triage, which is what you see here. With children, we use jump start. Classified as red tag being your immediate first priority patients, secondary yellow delayed, third priority are green or our walking wounded, and then our black tags are our fourth priority, and those are the ones that are deceased that we essentially have to kind of step over to go treat others. And that's a hard decision to have to make, but they're in the situation that there's a ton of other patients to treat, then that's what you have to do. And this is just going over different types of trauma. Domestic type situations with partners, whether they're somebody who is a current or former partner or spouse, are really common. And generally, these are the times where they are not going to tell you what had happened, or they're going to say they fell down the stairs, or they're going to have a story that just doesn't add up to you. And this is also where the person that's the abuser is going to stay around the whole time. He's not going to let you sit alone with them. He doesn't want you to, or he or she doesn't want you to try to coax or try to persuade the person to tell you what actually happened. It can be hard for us to recognize it because unless they're truthful with us, yeah, we can report certain things, but unless they're honest in the end, it's really not going to do anything. 4 types of violence that we can see is we have physical, we have sexual, stalking, and then physical aggression. Signs, again, is the patient answering questions to you, or are they concerned that law enforcement is there? Or is the person that potentially caused the abuse talking over the patient, answering questions for them? It's kind of hard to, you're in a bad situation when law enforcement responds to you with you to these types of calls, because yeah, you need it for your safety, but on the other end, it's going to be really hard for that person to answer questions because they don't want to get somebody in trouble. And I can't tell you how many domestic situations I've seen where, oh, they'll change. I love them. They're just going through a tough time. And they honestly want to blame themselves a lot of time. And it's sad to see, but unless they want to take the step forward to kind of say, hey, this is what's going on, they're going to kind of always be in a bad situation. Even if they separate, generally they end up getting back together. Like I said, these are pretty short lessons. So airway management. When it comes to trauma situations, it is going to be a little bit different when we look at assessing and managing. Is there potential that the trauma that has occurred is blocking their airway or is inhibiting their respiratory process? What management techniques do we have to look at? Maybe the head tilt chin lift is not the best option based off of trauma. Maybe we're looking at jaw thrust, and also looking at what adjuncts can we use. Things such as NPAs might not be the best option, especially if we're worried about traumatic brain injuries or any sort of facial fractures. Traumatic situations, especially to the face, there's a potential we have to suction. So that should always be something that you're concerned about. And traumas doesn't just have to be blunt force. This could be explosions. This could be fire. This could be a suicide attempt, such as hanging. There's a whole lot of different things that people don't think about. Our positioning, I mentioned before, maybe head tilt chin lift isn't best, especially if you think there's C-spine involvement. We just look at the jaw thrust, which is what you see here. The potential for suctioning based off of maybe some respiratory issues, maybe upper airway involvement. Again, NPA versus OPA. Do we have the concern for facial fractures? Do we have the concern for TBI? We want to ventilate the patient, but we don't want to ventilate their brain. And in traumatic situations, can we ultimately bag the patient? Maybe there's some anatomy issues to where a BVM won't fit on them, that mask won't fit on them correctly. Depending on what your service or what your area has, advanced adjuncts such as supraglottic, when you talk about like King LTs, iGels, LMAs, what you see it down at the bottom is a combi tube, which is something that used to be used prior to the King devices. Do we need to look at endotracheal intubation, or do we need to look at RSI? There's a difference. Endotracheal intubation, just plain intubation, is performed because the patient doesn't have a gag reflex, as opposed to RSI or pharmacologically assisted is a patient that has an intact gag reflex, and we're looking at sedating them and potentially paralyzing them to be able to perform an intubation. Or if all else fails, or we have no other options to gain an airway, maybe there's massive swelling, maybe there's anatomy issues that you just can't recognize the airway, do we need to look at the potential for a crike on this patient? So you're responding to a single vehicle crash into a tree. 27-year-old female. Crash occurred on a 4-lane highway at 9 o'clock at night on a clear night, 70 degrees. There is intrusion into the engine compartment. So front of the car has been pushed back into the engine compartment. Patient was traveling 50 miles an hour at the time of the impact. Patient was wearing their seatbelt, but there was no airbag deployment. Level 1 trauma center is 30 minutes, and local is 10 away by ground. So this is just a ground situation. 30 minutes versus 10 minutes. This is what you see when you arrive on the scene. What potential hazards, whether it's vehicle or scene, would you be concerned about?
Is there gasoline leaking?
Okay. Is it leaking gas? Is it leaking any sort of other fluids? Okay. What else?
That tree.
Airbag.
Airbags that haven't gone off, right? I heard tree. Is there potential that the tree's unstable? What about electrical shorts? Is there a chance that this vehicle still has power to it? Are there any sort of active threats at the scene? Again, is there potential that this car just explodes? That maybe a gas line was involved? So law enforcement is directing traffic. Fire personnel cut the battery cables and are prying open the jammed driver's door. So now our concern for electricity has been cut. They're forcing extrication through the driver's door. Patient is conscious and talking. C-spine stabilization is maintained throughout the process. No serious bleeding is noted. Going down our primary, no serious bleeding, small abrasion to the throat area. Patient talking to the firefighter, which is holding C-spine. Patient is breathing without difficulty, states her throat is sore. Has a pulse at the radial artery. GCS 15, able to move all 4 extremities. Patient remains in the vehicle as the driver's door is stuck. What concerns you about any of that information?
The sore throat.
A sore throat. Okay. What is this? What's her throat sore from? We know that she has a small abrasion to the throat, so we're going to have to guess that it was trauma. Maybe it was the steering wheel. Maybe it was something else in the vehicle. I'd also like to know, even though she's seatbelted in, what does the windshield look like? Is there potential for spidering? Did she hit her head on the windshield? But right now, she's acting appropriately. Is she maintaining her airway right now?
Right
Yes.
now, she
Right now, she is. Do you think there's potential for airway issues? I'm not going to say anticipate, but is there potential for it?
Possibly
Yes.
with the abrasion.
Okay, possibly with the abrasions. Physics of trauma of this crash that concern you regarding the patient's airway. Well, for one, the airbag didn't deploy. And like I mentioned, something hit her throat that caused that abrasion. So she is one that we don't have a whole lot of trauma to look at besides that small abrasion. So we look into our secondary survey, such as vitals. Heart rate's a little elevated given the circumstances. I get it. Carbon dioxide's normal, CO. She's breathing a little bit fast. Blood pressure's a little bit elevated, but again, given the situation, I mean, mine would be a little elevated too. So, I mean, right off the bat, there's nothing that terrifies me. And we'll just say a blood glucose is 128. Is C-spine indicated for this patient?
Yes.
Is airway management, and I'm going to change this, indicated right now?
Not now, but
No.
possible.
Not now, but possibly. What additional assessments can be performed while they are still in the vehicle? And what else would you want to know?
Was the dash pressing against the legs?
Okay, was there any sort of entrapment from parts of the vehicle? Was the dash pinned against the patient? Okay. What else?
Any bruising on the chest or abdomen?
Okay, is there any sort of other bruising that we notice?
Pupil response.
Okay, so maybe we're looking for potential for head injury, which she's acting appropriately now, but that's not saying one isn't, her brain doesn't start to swell and she starts acting weird 10, 15 minutes from now. So going into our primary, you don't notice any major bleeding. Airway is open, C-spine stabilized, complains of trouble swallowing. Patient's breathing, talking, and occasionally coughing. Does have a radio pulse, conscious, oriented, and talking, extricated, and now on a backboard away from the vehicle. How, and out of all these, this is the only one I'm going to ask, how would you determine if the patient has an adequate airway and is breathing appropriately?
End title.
End title's one of them. What's another one?
Their presentation, how they're mentating.
Yeah, talk to them. How are they presenting? She's complaining of trouble swallowing. So again, right now, I don't think there's an airway concern. Maybe I'll put her on some supplemental oxygen, but that's something that I'm going to be watching closely. Patient has coughed up some blood, complains that her throat is really starting to hurt now. There's increased redness to the patient's midline neck at her thyroid cartilage. Do you think the patient is stable or becoming unstable at this point?
Unstable.
Okay, I would agree. What do you think is causing her throat to hurt? How would you manage it, and what is your backup to managing it? I'm going to go ahead.
RSI.
Swelling.
Everybody talk to one. Sorry.
Swelling.
Swelling due to an injury. Okay. I would agree with that. As far as management, knowing that this sounds like it's getting worse, I'd also be listening to how the patient's talking. If there's a potential that I need to RSI this patient, then that's the route that I'm going to go. Because if I wait too long and I allow that swelling to continue, then I would lose the airway and then I have to look at a crike. Backup, if you can use a supraglottic, maybe an intubation fails, or again, that's if you go that route. But always have a backup to your backup. And this isn't going to be swelling that occurs like instantaneously, like you would see in anaphylaxis. This is going to take a little bit more time, 10 to 15 minutes roughly. There is a difference, obviously, between peds and adult airways. Kids are a lot more floppy. They're not as formed. They don't have those cricoid rings formed as we do as adults. As to where adults, we have almost a clearer view. Kids have a lot larger tongue, and it's a little bit more difficult to intubate them. And it's something that we don't do as frequently. So it also gets our blood flowing and gets us stressed out a little bit. Lemon is something that we use to assess how difficult of an intubation is going to be. Looking at them externally, is this somebody that has no neck? Is it somebody that has a long neck? The 3-3-2 rule, which is, using your fingers to determine how far they can open their mouth, looking to see how far away their chin is away from their chest. The Malampati, which is what you see here, class 1 through 4. I'll be honest, I've never done that in my career. Is there potential for obstruction? And are we concerned about neck mobility? In this instance, neck mobility would be a concern because there's C-spine precautions going into play. Intubating somebody with a C-collar on is not exactly the easiest. So if you have to intubate somebody that has a C-collar on, maybe it's removing the C-collar, having somebody hold manual C-spine so that you can perform the intubation. Another tool that we can use to assess intubations is what they call Heaven. So we're looking at hypoxemia, or reasons we would intubate, extremes of size, anatomic changes. Maybe there's blood, vomit. We're concerned about airway involvement. Maybe there's massive bleeding, and then neck mobility as well. This is something that isn't quite used as often, and it's something that is kind of fading out in PHTLS, to be honest, as we use Lemon more often. Making sure that you have all of your equipment ready to perform an intubation, and in addition to your equipment, have your backup equipment ready. Hopefully your airway roll, your airway bag, whatever it is, has all of the options right there so you can easily grab them. Now, when it comes to medications, would you pre-medicate this patient? In what order would you push the classifications in? Or name some of the drugs.
Ketamine.
Okay, ketamine's a good one. Dissociative. So the patient kind of really doesn't know what's going on at that moment. What else?
Rock or sex.
Okay, rock or Vec. So there's Sucks as well. Sucks is more, it's a lot shorter lasting as opposed to rock or Vec, which is good for if you get a failed intubation, it wears off a lot quicker. The problem is it can't really be redosed. Rocuronium lasts a lot longer. So a problem with that is if you miss the intubation, you got to manually bag that patient for the whole time. But again, that's what backups are for. Generally, we pre-medicate with something such as fentanyl. We can look at ketamine after that or etomidate after that. And then we would look at the paralytic. The paralytic should be the last thing we're doing. I'll be honest, the times that I've RSI'd somebody, there's been a handful that I haven't even had to use a paralytic. I check to see if their gag reflex is gone after I give a sedative. If it is, great. I can perform the intubation. I don't have to use a paralytic. What would you want your partner to do if you're going to intubate this person? How would you want your partner to get them prepared?
Pre-oxygenate.
Pre-oxygenate, right? Absolutely. If the patient is conscious and able to understand things, tell them what is going on. Don't hide it from them. Be honest with them. How are we confirming intubation in a patient?
Auscultation.
Okay, we're listening, right?
Title.
Capnography.
Capnography, end tidal, we're looking at waveform, we're looking at numbers, we're oscillating. Now, remember, if you are going to push that tube too far, generally it's going to go in the left lung because that's a straight drop, or right lung, sorry, straight drop from the oropharynx, as opposed to the left branches off a little bit more. So it's very hard, in my opinion, especially in a stressful situation, to listen to lung sounds, but that's why we have backups. Whether it's a colorimetric device, whether it's using capnography, whether it's using end tidal, have additional means for determining if your patient is intubated correctly. One method to confirm intubation that people often don't think of is you visualize it go through the cords. And that's something you should document in your report. Are you transporting to your small hospital or your level 1?
Level 1.
I would go level 1, especially if the patient's stabilized. So during transport, patient's intubated, SpO2 alarm goes off, and the patient's now 89%. End tidal drops to 35. Does anybody remember the mnemonic that we use for intubated patients to determine what could be going on?
You're talking about dope? Is that
Dope.
what you're
Yep. Dope mnemonic. Is the tube dislodged? Is it obstructed? Is there potential for a pneumo? Or do we have equipment failure? These are all things that we should be checking in that order to determine what potentially went wrong. Patient ultimately transported to level 1 trauma center. Patient had to have a temporary tracheostomy due to laryngeal swelling. Patient has since been discharged from the hospital and is doing well. Visit your EMS station to give you some cookies. Look at that. Look, that's nice. Airway should always be something that we focus on if we're not concerned about massive hemorrhaging. And again, this could be the airbag did go off and that powder that explodes in everybody's face. Maybe they're coughing a whole lot. Maybe they feel like the throat's closing. That's something we need to be watching while we're transporting our patients. Once you perform any sort of airway intervention, you need to be constantly reassessing your patient to see if there was any change in patient status or if the patient has declined. All right, we'll go through this next one and I'll give you guys a break. So we covered airway. Now we're looking at the breathing. How are they perfusing in regards to the respiratory system? So you're responding to a practice field of a local high school baseball team. 16-year-old male struck by a wild pitch during batting practice is experiencing difficulty breathing. Level 1 is 15 minutes away by ground. Level 4 is 5 minutes away by ground. So 5 versus 15. Players direct you to the patient. An athletic trainer is with the patient. Numerous concerned players and coaches are around as well. They always are. Patient is alert and oriented, sitting in the tripod position, holding the right side of his chest, and he appears to be in distress. Primary survey, there's no massive hemorrhaging that we have to worry about. Airway is patent. Patient is breathing 30 breaths a minute with diminished lung sounds on the right side in conjunction with severe difficulty breathing. Lips and nail beds are cyanotic, so we start to develop maybe some potential for hypoxia. GCS at 15. You notice bruising to the right side of the chest along with crepitus upon palpation in the area. No chest expansion on the right side of the rib cage. What is our concern for injuries with this patient?
Pneumothorax.
Potential for attention pneumo based off the trauma. What else?
The hemo and Nemo. Yeah.
Okay, maybe it's a hemothorax. What about how the ribs aren't moving on that side? What potentially anatomy issues could we see there?
A flailed chest.
Possibly a flail chest from the injury. Patient 16 years old, breathing 30 times a minute, so it's a little bit fast. At what point do you think you need to begin to assist ventilations with this patient or assist with oxygenation?
Provide oxygen right away.
Okay, you can put supplemental on right away. Absolutely, because it might even calm the patient down. When it comes to assistance, that's when the patient is honestly having trouble breathing or they're starting to get tired of breathing. Now, the biggest concern, in my opinion, is the absence of breath sounds on the right side associated with the flail chest. That screams that this patient potentially has a pneumo all day long. There's certain things you need to determine if we are going to perform a procedure such as a needle decompression. You have to have absent lung sounds and you have to have difficulty breathing. We happen to have both of these. That's the bruising that you see. That's why it's important that we expose so we can see these injuries. Now, if you look at the x-ray on the bottom side, what do you notice about the right side versus the left when you're looking at the lungs, the darker spaces?
The left side is darker.
Okay.
There's a chest tube there.
In this instance, there is a chest tube on the right side. But what do you notice about and this isn't this specific patient, but what do you notice about what is that darker area over here telling you to the right side of the picture versus the left side of the picture? When it's darker like that, it's filled with air, is generally what that means. As you can see on the left side of the screen there, you almost see tissue. Now, what we don't know is that, again, potentially this is a hemothorax, and maybe that's why there's a chest tube on that side. We honestly can't differentiate hemothorax versus tension pneumo. One's air, one's blood. Middle of the bruise moving the opposite direction, we mentioned the flail chest. When the patient goes to breathe out, that might actually suck in. Or, when the patient inhales, it sucks in. When the patient expires, it blows out. And it's paradoxical movement. It won't match the other side of the chest. If you ask that patient to take a really big, deep breath, I'm going to guarantee that they're not going to. I'm guessing his respiratory rate is increased because he's taking shallow breaths because it hurts to breathe. The worst sound that we can hear is no sound when it comes to auscultation. Treatment priorities. Are you more concerned about the flail chest or the absent lung sounds?
Absent lung sounds.
I 100% agree. How do we even manage a flail chest?
Used to be pillows or something, push up against it.
Yeah, like
That's still what it is.
we used to actually use sandbags back in the day. It was something that we carried on the end of smaller sandbags. We would put against the chest and we would wrap it. Now they've pretty much said just wrap the chest. I mean, a pillow is not going to hurt it, but they pretty much just say wrap in Coban, or if you have larger gauze, just to help stabilize it. And then you would assist ventilations if need be. Ventilation issues, if we have to assist, by all means, maybe again, and I'm not saying for sure, maybe by a needle decompression, we improve ventilation. Maybe we improve oxygenation at that point as well, because the patient can breathe a lot easier. What is the difference between assisting and providing ventilations? And how do we assist?
Assisting,
Sorry, go ahead.
assisting their breathing on their own, providing we're breathing for them.
Yeah, assisting, they take a breath in. That's when we help them out. They go to exhale. That's when we let off the bag. As opposed to they're not breathing at all, and now we're providing breaths for them. Knowing that there is a certain level of trauma here, are you fine with that level 4, or are you going to go the 15 minutes to the level 1?
Really, it's just an extra 10 minutes difference. I would go to the level 1.
Okay, I would agree. Assessments and procedures need to be performed during the transport. I'll be honest, if I don't hear lung sounds, I want somebody else there to listen as well, because maybe I'm just having a bad day and I just can't hear them today. I want somebody else on the scene to verify what I'm hearing. I also want to be able to put this patient on end tidal. I want to look and see what their waveform is doing. I want to see if I'm starting to lose oxygenation and I'm seeing an increase in end tidal, because that's telling me that the patient is not able to blow it off. Trauma patients, I think I told you guys wrong before that we want them higher. It's actually lower, 30 to 40. And you're going to see that most of the time because they're breathing faster. They're worried, they're anxious, they're blowing off a lot more carbon dioxide. So in this situation, if you start to see carbon dioxide build, that's odd because he's breathing fast. But they're just shallow breaths because it hurts him to breathe because of that flail segment. Knowing that normal capnography looks almost like a square, right? If you see the bottom 2 there, A is going to be what is pretty much normal, an end tidal of 45, as opposed to the one on the bottom. What is the one on the bottom indicating? And it says it there, but
ROSC, yeah.
Yeah. Anytime during an arrest, you see an end tidal of 10 or greater, you have a really good chance of getting ROSC on this patient. And again, you see a massive jump in end tidal like you see there from we'll say almost 20 to 60. That's huge. That indicates that now we have perfusion with our patient. Top one is indicating a patient that is going into shock or is starting to hypoperfuse. You can see they're essentially going to draw out to nothing or flatline and go into an arrest. And then the bottom one is like the shark fin appearance. And primarily we'll see that in patients with lower airway, like bronchospasms, such as asthma. Secondary survey of this kid, heart rate's 128, pulse ox is 90, end tidal's 40. And you can see the end tidal isn't coming back down to baseline. So he's taking very quick, shallow breaths. Respiratory rate of 30, BP is 118/54. Secondary survey was completed. Patient transported to level 1 trauma center, treated as an adult, did have a flail segment as well as a large lung bruise. Patient was intubated, admitted to the ICU, and heals after a short stay. There was no decompression. Now, let me ask you this. If you perform a decompression on this, would you be wrong based off of what was presented? Absent lung sounds and difficulty breathing.
No.
No, you're not. I would beg you to look at your protocol for the procedure of needle decompression, and I'm going to guarantee that those two things are on there: absent lung sounds and difficulty breathing. It's also the skill that we mess up the most as paramedics because we don't perform it that often. It's really hard to determine unless you have something such as like the bruising, or you have the story such as the baseball hitting the kid. Otherwise, respiratory patients, in my opinion, are some of the hardest to diagnose what potentially is going on with them. Maybe this is a kid that we just assist ventilations. We wrap his chest, assist ventilation on the way to the hospital, as long as he's able to maintain. Last thing I want to do is have to intubate a kid in the back of an ambulance, even if he's 16 years old. Ventilation versus oxygenation in trauma patients. We can have a mismatch. The patient can be ventilating, but maybe due to blood loss, isn't oxygenating or isn't getting the gas exchange in their lungs because the air isn't getting deep enough. You can have a patient that is obviously intubated and you're providing supplemental oxygen through the bagging. You can have patients that are in CPAP and still be able to provide oxygen even through a nasal cannula under the mask. Do not rely off of SpO2 on any patient. And I keep saying that. Rely off of end tidal in your assessment of them, of what potentially is going on. All right, let's take a 10-minute break. We'll say at 7:07, we'll come back and finish the last half of this. All right, we're just about halfway through this. Circulation is one of the longer lessons, as it's something that PHTLS focuses a little bit more on when we talk about how to manage those life-threatening injuries, and we talk about what blood loss really means and how much blood loss we should be worried about in different classifications of it. So you're dispatched to a 40-year-old male who was on a motorcycle, went out of control while passing a car. Patient is lying on the ground with blood noted around him. You can kind of see from the picture there. I hope that's not a puddle of blood underneath the bike, kind of coming towards the camera. Motorcycles laying on the side of the street. Traffic stopped by law enforcement. Patient is lying in a pool of blood beside the bike. Bike does not appear to be deformed. What does that information right there tell you?
Maybe he wasn't going too fast.
That's what I was thinking. Maybe he wasn't going too fast, but fast enough to where he got some sort of injury, which there's obviously some bleeding happening. Primary survey: patient has profuse bleeding from an anterior neck wound. Airway tenuous with sonorous respirations, so like snoring. Patient is breathing fast with shallow chest rise, has a rapid thready pulse. unconscious, but moves all extremities to painful stimuli, and is lying on the ground next to his bike. So he's not pinned underneath it. Do you think that based off the rapid thready pulse and what's going on in blood loss, is the patient potentially in shock? And what type of shock would you think?
Yeah, he's in shock, hypovolemic.
Okay, hypovolemic. Could it be neurogenic? I mean, can you have multiple things going on? It could be a neurogenic shock. It could be hypovolemia and secondary to neurogenic. I mean, there's a whole bunch of hemorrhagic shock. Why for us are these instances time sensitive? What don't we carry?
Blood.
We don't carry blood. And you can give as much saline as you want to a patient. All it's going to do is thin their blood out after a certain point. Neck wound. How, besides manual pressure, depending on where it's at in the neck, that's where you could absolutely pack the wound if needed. Bleeding is controlled with manual pressure. Helmet is removed. Why do we remove the helmet in motorcycle accidents? What's a reason we would remove it?
To get better access to his airway.
Yeah, if there's potential that we have to manage the airway, that's the time we would look at removing the helmet. Perform a trauma chin lift to open the airway. Breathing fast with equal chest rise, clear breath sounds. Great. Pulse is still rapid, thready. Patient is regaining consciousness and still moving all extremities. He is covered to maintain normal thermia. Patients in shock cannot regulate their temperature. That's why we always say try to keep them warm. Based off of the bleeding, is a tourniquet warranted in this situation? He had bleeding.
No.
The only thing we got was the anterior neck. Please do not put a tourniquet on somebody's neck. Tourniquets work by compressing the artery up against muscle. What I'll tell you is like what you see in the picture there. You've got the strap, and then you've got the actual buckle and the windlass on the top of the leg. Your arteries run on the inside of your legs, like groin area. So what I'll tell you is if you can place that buckle closer to the inside of the leg, the better chance you have at stopping the bleeding earlier, because it's going to actually compress it versus pulling the belt to compress muscle into the artery. What happens if one tourniquet isn't working?
Add another above it.
Add a second one above it. External bleeding still controlled by direct pressure. Airway is patent. Patient's breathing 24 breaths a minute with good chest rise, clear and equal breath sounds. Pulse ox is 97%. Heart rate 110 beats at the carotid and radial. Oh, so carotid and radial. Skin is cool to the touch. Conscious now, GCS of 15. Moves all extremities. Abrasion and bruising noted to left upper quadrant. Determining blood loss for us is horrible, because and this is a perfect example, is if you take a 1 liter or a 2 liter bottle of pop and fill them with water and dump it on the ground, how much space is that going to cover? Or is it just going to pool in one little spot?
Quite a bit.
It's going to move quite a bit, to be honest. Yeah, blood's a little more viscous, it's a little bit thicker, but sometimes we're quick to freak out over blood loss when really, unless we start to experience that 3 to 4 liters in loss, we're not going to notice a change in the patient. Classifications of hemorrhaging are based off of blood loss volume. Now, it's almost impossible for us to say, well, that's 1 liter of blood, that's 2 liters of blood. But we can know things based off of certain vital signs and how the patient is presenting. So in this instance, we'll say close to 1 liter. We're looking at a class 1 hemorrhage. Ventilation is normal. Patient's breathing fine. Heart rate isn't even elevated. I mean, the body is normal at that point. You can lose almost a full liter before, and nothing. You'll notice no changes. Patient's slightly anxious because of what's going on. When we get to 1.5 is when we start to notice some things. Patient's respiratory rate increases. This is where we see the heart rate start to increase and start to compensate for blood loss. BP is still normal, so we're in a compensated form of shock potentially. Pulse pressure decreased because, again, we have 1.5 liters of blood loss at this point, 1,500 mLs. Skin is cool. Urine output will delay at this point. Why does our body stop? Why do the kidneys stop doing anything?
Hold volume.
Yeah, it's trying to hold on to volume. Absolutely. Class 3 hemorrhage begins at 2 liters or 2,000 mLs. This is when the patient can start to develop maybe some early stages of confusion. Again, they're breathing fast, their heart rate's elevated. But now we're seeing a heart rate that's elevated with a blood pressure that's decreased. Pulse pressure is decreased. Maybe we don't feel a radial pulse at this point. We're only feeling a carotid. Urine output decreased even more. Class 4, anything 2,500 and above. Patient could be unresponsive, unconscious, severely confused. Respiratory rate is super fast for the patient. Heart rate is almost like SVT. You might not even feel it, it's going so fast. BP decreased, pulse pressure decreased, and now the patient has no urine output. This is the times, and it probably says it in here, do not rely off of your automated blood pressure. You should be getting a manual blood pressure on your patients. And again, we use something called permissive hypotension. If we can maintain our patient at 90 systolic, then that's what we do. And that's where we can statistically still be perfusing their organs. Ideally, we want to perfuse them until they're somewhat alert and able to answer questions. But again, if you can maintain 90 systolic, then that should be the goal. We used to just dump as much IV fluid in 2 large bore IVs. But what we didn't realize is we were washing away clots at the time. Now, there are some considerations. Athletes, they have lower heart rates than normal. So their compensation heart rate might be a little bit lower. Geriatric patients, same thing with their heart rate, maybe in conjunction with medications or their medical history. Pacemakers, peds patients whose heart rates are already elevated, and pregnant patients who already have a higher blood pressure than normal. When we are giving IV fluids, we are just looking to maintain perfusion for very temporarily because it's not blood. Again, you can give as much fluid as you want, crystalloids. Nothing will replace blood, because when we lose hemoglobin, we start to lose oxygenation and we start to lose saturation. I brought up the permissive hypotension. It should be titrated to the patient's mental status or that blood pressure of 90 systolic. Blood has a lot of advantages. It restores blood volume. It restores oxygen carrying capacity. It also assists with clotting, something that, again, we can't do with normal saline. Problem is it's limited logistically and technically. It's not carried by everybody. A lot of times it's beyond the reach of us as EMS providers, and we have to rely off a helicopter or that level 1 trauma center. Resuscitation objectives are going to differ depending on what's going on. Normally, we're just looking at restoration of a normal blood pressure. But in like penetrating trauma or internal bleeding, our fluid resuscitation is going to be titrated just to a certain pressure because we don't want to wash clots away. This is that TXA that was brought up earlier. So really, what is TXA? Well, it doesn't promote clotting. It just prevents the clots that you have from being broken down, from the body breaking it down. It is FDA approved. A lot of times you'll see this. Some EMS agencies are starting to carry it. You'll see level 1 trauma centers carry it as well, and they'll administer it pretty frequently, to be honest. There are some side effects with it: nausea, vomiting, hypotension if it's given too quickly. Now, again, primarily we are using TXA for internal hemorrhaging that cannot be addressed with things such as tourniquets or wound packing. This is for the things that we cannot see. Generally, it's given, I want to say it's 1 gram into like a 100 ml bag of saline and infused over 10 minutes. It's not given very rapidly. If you notice, if for some reason we're giving TXA or you see a TXA given and you see a drop in blood pressure, you need to slow down the infusion. So homeostasis, our body likes that 98.6 degree temperature. Problem is, if the patient becomes hypothermic, then there's an increased oxygen demand for cells. Well, we have an increased oxygen demand for a patient that maybe doesn't have the oxygen carrying capability. Hypothermia affects cellular functions. It makes it so that clotting is diminished, so we're not able to clot as easily. How do we prevent it? Maybe we're looking at giving warmed IV fluids. Maybe we're looking at covering our patients. Just kind of depends on what we have at that situation. This guy, that motorcycle man, bleeding is controlled by pressure dressing. Airways patent, respiratory rate has slowed down. Heart rate has slowed down to 105. 18 gauge IV in place with lactated ringers running TKO. I don't know of really any EMS services that carry LR. Primarily LR is given when we're concerned about like infection or like burns. GCS 15, no neurologic deficit, body heat maintained with blanket and warm environment. We're transporting to a level 1 trauma center. Secondary survey was completed. We went through a medical history with the patient, went through a secondary, more focused, detailed exam. Patient is found to have a ruptured spleen with internal bleeding. Undergoes a surgical splenectomy and makes a good recovery after 5 days in the hospital. What are some things that, how we could determine if somebody has a ruptured spleen? Is there anything?
It's
Not
first
really.
sign.
Unless we get, Cursign would be more like your, you'd see that primarily more with gallbladder to your right shoulder. When it comes to spleen, the only thing we would really see is potentially bruising on that left side. If we're concerned about, if there's ever concern for massive trauma to the abdomen, that is something that they always kind of lean towards because it is solid and it lacerates pretty easily, kind of like your liver does. Any trauma doc you can talk to. I went to a trauma conference a couple years ago, and that was the big thing that they were hitting on at the time is stop overloading our patients with IV fluids because we are thinning their blood out to the point that they're not oxygenating. They're not able to clot. We're washing clots away. Do just enough to maintain perfusion in our patients because otherwise we'd lose the ability to oxygenate them. Transport them to places that we know have blood carrying capabilities, keeping them warm so that we're not increasing their oxygen demand. If your service or a service around you carries blood in the field, by all means, if you have to call for a helicopter, then that's what you have to do. But nothing will replace blood replacement. Before we get into this, what is a secondary survey? There's 2 different routes it can go. In a medical patient, it's what? What are we asking them? Generally, this is our sample and our OPQRST. That's our secondary survey. In trauma patients, we can still go down that route, but maybe we're doing a more focused physical exam in our secondary survey, as opposed to that rapid one that we did when we first came to the patient. 40-year-old male has fallen off a roof. Saturday morning in early November, patient lost his balance and fell 12 feet from the roof. What of any of this concerns you?
The height that he fell,
Okay, 12-foot fall height.
and possible the weather. if it's early
Okay.
November.
Okay, let's say the outdoor temperature is 42 degrees. 12 feet could be a small 2-story building. I mean, generally they say 10 foot is a story, or 8 to 10 feet. That's a significant fall, especially depending on how he hit. Let's say he landed on his back. He was cleaning leaves from the rain gutters, lost his balance, fell, and hit his back. Let's say, let me throw something else out in here. Let's say he lost consciousness for a brief period, but was conscious by the time family called 911. So just kind of keep that in the back of your mind. You arrive, you see the ladder laying on the grass, patient lying on the grass beside the ladder. He fell. We get it. No visible signs of hemorrhaging. Airway is patent. You see no airway obstruction. Your partner is holding C-spine. Diminished. Breathing is shallow with diminished sounds. 28 breaths a minute. Unable to take a deep breath due to upper back pain. Skin is pink, cool, and dry. Pulse is 138. Pulse ox 94. End tidal 35. Patient is conscious but confused to fall. Pupils are 3 millimeters and equal bilaterally. Again, temperature outside is 42 degrees. What concerns you about any of that? Or things that jump out at you?
Respiratory rate.
Okay, respiratory rate. Lung sounds could be diminished because he's breathing very shallow. He's not taking good deep breaths, so we're not able to hear it. The confusion, some positives is that his pupils are equal bilaterally. Are they sluggish to respond? Maybe there's potential for head injury, but remember, he landed on his back. Would you stay and play, or are you performing your survey in the back of an ambulance on the way to the hospital?
Let's go.
Let's go. See, hear, feel. Use our senses in these patients. This is where we kind of got to get personal with them. Looking at their head, working their way down neck, chest, abdomen, going to our lower extremities, checking our pelvis. Maybe, in males, if we have priapism, that could indicate somebody has a potential for a spinal injury. Rolling them so that we can look at their back, checking their extremities, making sure that they are symmetrical. Do things match from one side versus the other? What are things that can be heard that are concerning to you? Let's just say with this patient, if you were to hear something, it would make you a little nervous.
Crepitus.
Okay, crepitus. What
Maybe
about
it's not what you heard, but what you didn't hear.
bingo? Maybe we've got some, it's not what we heard, it's what we didn't hear. We didn't hear lung sounds. Another thing that we hear is the patient's confusion, the inability to speak in full sentences. Maybe there's a potential his speech is slurred. We haven't been told that, but when you're feeling for injuries, and this goes back to combat medicine, what are your hands telling you? And what are you looking for with your hands? You're feeling for any sort of deformity, and you're also pulling your hands away to look to see if you've got blood on your hands. That's something that they did very rapidly in the field, is they do a quick assessment. They'd run their hands from somebody's head all the way down their body to see if any blood appeared on their hands. I get very nervous trying to feel somebody's neck, or like turning their neck or something like that, or there's potential. That freaks me out. When we talk about feeling the patient's chest, maybe we're feeling for crepitus. Maybe we're feeling for, is there any sort of air trapped? I mean, that can tell us that we have some internal injuries. Is this I'm going to reassess every 10 minutes, or I'm going to reassess every 5?
Every 5.
It's a priority patient. What can you tell from looking into somebody's eyes? Well, for one, examining their pupils, you can determine if there's any injuries to their eyes, or if there's maybe a potential for an underlying head injury caused by an edema or a hematoma. And you can also see if they're able to follow you, if their eyes are working, if they're constricting, if they're dilating like they should. Use your pen light, see if your patient's able to follow your movements with their eyes. There's nothing that replaces a good manual blood pressure. Even now, if I transport a patient, I hate using the cardiac monitor. Yeah, for my general run-of-the-mill patients, I get it. But more often than not, the cardiac monitor is off a little bit. And a lot of them will default, or not default, but air out if a pressure is too low or a pressure is too high, depending on what settings are set for your monitor from the manufacturer. Check for manual pulse. I still do that on all patients. I walk up to them when I'm talking to them, I check for radial pulse and I feel it. Actually counting respirations. I get it. We always put 12 to 16 or 18 on our paperwork now, but there are instances where we should be actually counting respirations. That's why I'm a huge fan of wearing watches still, and actually being able to look at the seconds and actually being able to count. Some ambulances have them in the back now that you can time it, but it's just something that a habit that I have to always have a watch on me. Oxygen saturation, for one, is breathing inhibited? Is there concern for the mechanical process, or is there concern for blood loss that is leading to some oxygenation problems? Our end tidal, is it low or is it high? How is the patient breathing? Are they breathing shallow or are they breathing deep? Glucose, in this instance, why would glucose matter?
Because of the confusion, you want to rule out low glucose.
Yeah, or the fall. Did this potentially cause the fall, or did it lead to the confusion? Other part of our secondary survey is going down sample. Signs, symptoms, allergies, meds, past medical history, last thing they ate, and events leading up to what had happened. See if they can remember that. Here's our patient's vital signs. What two things jump out at you? Respiratory rate is concerning, but yeah. What else?
Blood pressure.
Blood pressure in conjunction with what?
His
Heart
heart
rate.
Heart rate. That tells me he's in some sort of potential shock. Secondary survey shows the patient has upper and lower back pain. An unstable pelvis was found, which could be causing lower back pain. Patient's neurologic exam is within normal limits. Your pelvis hides a lot of blood. I mean, again, the patient will compensate until they don't at that point. I want to say it can hide like 4 liters of blood, if I'm not mistaken. It's a large amount. Secondary survey completed en route to the hospital after primary completed on scene. Transported to a level 2 trauma center, which the only difference between a level 1 and level 2, level 1 can perform their own research, a level 2 cannot. As far as treatment wise, they're pretty much the same. Patient was found to have a minimally displaced pelvic fracture, concussion, and contusions to his upper back. Spent 4 days in the hospital and a week in rehab before going home for continued recovery. So it mentions nothing about bleeding into the pelvis. What else could be causing low blood pressure and a high heart rate? What other form of shock could potentially do that?
Neurogenic.
Maybe it's like a spiral cord shock or a form of neurogenic. Neurogenic's more like prolonged, but I'm just talking maybe it's shock to the spinal cord, just something that's immediate that doesn't last very long. Your secondary is your search. That's when you get to play detective. That's when you get to ask questions and look for things that are potentially causing what is going on with the patient. TBI, traumatic brain injuries. It is very common when we talk about injuries. TBIs occur in instances where we don't even think they'll occur. Car accidents, people falling off their bicycles, people skateboarding, people rollerblading, people just walking. In our elderly population, we see TBIs happen all the time because they tripped and fell at home. when it comes to our kids, TBI is very common, and it's something that actually causes most death and disability in our younger population in the US, at least as of 2020. Motor MVCs is the leading cause of TBIs among all age groups, 60%. Besides that, we have falls, and then it would come into like violence, and then right below that would be like workplace or sports related injuries. So MVCs account for 60% of the TBIs that we see in all age groups. So you're dispatched to report of a male who was riding at a skateboard park, fell and hit his head. Seen as safe. You have a 22-year-old. His friend tells you they were trying to see who could ride the longest down the rail when the patient fell. Patient struck his hand first, then his head on the concrete. Patient was not wearing a helmet. Seen as safe, patient is lying prone, and you notice a hematoma and abrasions to the right side of his head. In terms of bleeding, oozing dark blood from the right side of the head, open fracture of that right radial radius and ulna in his arm. No active bleeding from there. Airways patent, no airway obstruction. Your partner is holding manual C-spine. Increased rate of breathing, lungs cleared bilaterally. Skin is pale, warm, and dry. Heart rate 100, SpO2 90%, 92%, end tidal of 32. So he's breathing a little bit faster. So our end tidal is going to be a little bit more delayed, or a little bit lower, sorry. Patient is conscious but confused, GCS of 13. So he's losing a point on eye movement. He's losing a point on verbal response. Pupils 3 millimeters and equal bilaterally with sluggish response to light. Outside temp is 78 degrees. Patient's skin temp is normal. What does a sluggish response have the potential for telling us when we're talking about pupils?
Swelling of the brain.
Maybe some sort of herniation of the brain or some sort of traumatic brain injury. The brain is very unique, especially when it comes to trauma. We have things such as like secondary impact syndrome, and those are things such as like CTE or people that are in sports such as boxing, that over a prolonged period of time they develop injuries based off of their profession. We also have the potential for hypoxia, which applies to every patient with an altered mental status. There's a possibility of hypoventilation, airway obstruction, potential for hypotension due to herniation. So a lot of other body functions are controlled by the brain, especially in trauma situations. The brain reacts differently, and that affects all the other senses, all the other sensations, the way our body functions. We have to have oxygen. We have to have glucose that's carried by blood. So if we have a reduction in blood supply to the brain, we have a reduction in fuel. If a patient's BP decreases, cerebral perfusion decreases. The blood circulates in the brain. This causes blood vessels in the brain to dilate, allows more blood into confined space of the skull because blood's not moving effectively, and leads to an increase in intracranial pressure because it's occupying that dead space and actually pushing pressure on the brain. Why is it important that we look at airway management in a patient with TBI, or why is it something we should be considering?
We can cause increased intracranial pressure.
Okay. Increasing intracranial pressure can also lead to the patient not breathing correctly. It could lead to sporadic breathing, which could lead to an increase in end tidal or a decrease in end tidal. Could lead to a decrease in oxygen saturation. In this instance, do you think that airway management is necessary for this patient right now? Probably not. Patient's end tidal was 32. So again, that tells us he's either breathing too fast or he's taking big, deep breaths. Cerebral perfusion pressure, again, is just the amount of pressure needed to maintain cerebral blood flow. That's normal when we talk about like MAP, mean arterial pressure. MAP ranges, normal range is 85 to 95. Sudden increase or decrease in blood pressure, or MAP, and intracranial pressure may affect cerebral perfusion. So if we have pressure pushing on the brain, it's going to decrease cerebral perfusion. If we have less blood flowing to the brain, it's going to decrease cerebral perfusion. That's where we potentially have patients with an altered mental status. Initially, we can pretty easily put somebody on oxygen. Based off of the injuries, is C-spine indicated?
Yes.
Yeah, absolutely. He's got a head injury. What do you see in this picture without me even explaining it to you? What do you think is going on there?
Possible subdural hematoma.
Okay, he's got a hematoma, right? That's more than likely blood pooling up right there. As that pools up, is that putting pressure on the rest of the brain?
Yes.
Yeah, absolutely. That's where how ICP starts. There's different types of intracranial hemorrhage: epidural, subdural, subarachnoid, intracerebral. This is just talking about parts of the brain. Epidural, the outermost layer; subdural, innermost; subarachnoid, intracerebral, so a vessel in the head itself, in the brain itself, has burst. The potential for cerebral laceration is pretty low, because the skull is, again, like a little vault. It's very thick, and it takes a lot of pressure to actually crack the skull. It is very much, like I said, our little safe. Now, if you have somebody that has a skull fracture, that does indicate significant force. Maybe this kind of skateboard was going really fast. It also suggests potential for further injuries, and it raises our index of suspicion for brain injuries. Some common signs and symptoms of concussions: vacant stare, patient just isn't acting right. Maybe their speech is slurred. They're not able to, when we look at like pulse motor sensory, they can't follow commands. They have deficits. They can't tell you what happened leading up to the event. Epidural, subdural, intracerebral, I kind of talked about this a little bit, but I'll show you. Epidural, it's generally associated with like a front temporal skull fracture. Not always, but blood collects in the epidural space, which causes an increase in intracranial pressure. Signs and symptoms generally: loss of consciousness, followed by a return to consciousness, to where the patient could then lose consciousness again. So they are unconscious, they regain consciousness, and they're unconscious again. That's really textbook for an epidural. As opposed to a subdural, this can take hours, days, or weeks to really develop. And this is, again, on the inside layer, pushing directly on the brain. You'll see a deterioration over a prolonged period of time. It's nothing that's going to happen subtly. This is also where you'll start to see unequal pupils. Generally, the dilated pupil is on the side of the injury. So if the left side is dilated, generally they have an injury to the left side of their brain. If they have like weakness or paralysis on one side of the body, the problem is usually the opposite of that. So if they have weakness and paralysis on the right side, generally it's a left-sided brain problem. And you could also potentially see seizures with subdural hematomas. Diffuse axonal injuries is really looking at damage to nerves. Is there potential we have a shearing injury, or we've lost blood supply for long enough to where nerves are dead? Symptoms: it'll very much present like a traumatic brain injury, loss of consciousness, increased intracranial pressure. As far as treatment for this, there really is no specific treatment. A lot of times when we look at intracranial pressure, they'll look at like putting a drain or a bolt in to relieve that pressure, or do a craniotomy and remove part of the skull just to allow that pressure to build without causing intracranial pressure. Secondary survey: patient has a laceration in the right temporal region with a depression of the skull. Remember, that's closely associated with an epidural. Pupils left 3 millimeters, right 5, and non-reactive. So we have an injury to the right side, and we have a pupil on the right side that's bigger than the left. No pain or step off with the neck was noted. Lungs clear bilaterally, no noted injury. Abdomen is soft, non-tender. Pelvis is intact. Patient has an open fracture to the right arm. Are you really concerned about the right arm right now? There's no major bleeding. Probably not. That's on the lower end of my treatment. I need to do some other things before I focus on that. Vital signs, heart rate 56, end titles 48, respiratory rate of 10, blood pressure is now high. Does anybody remember the three things that make up Cushing's triad?
Hypertension and bradycardia.
Hypertension, bradycardia, and a sporadic respiratory rate, or respirations that are kind of all over the place. Those make up Cushing's triad that is really leans us towards the patient has a head injury. So we've got that here. We've got blood pressure that's rising and a heart rate that's decreasing. That generally indicates a rise in intracranial pressure. Unequal pupils, again, he had an injury to the right side of his head. I'm going to guess that the right side being blown, being larger than the left, is just another thing that's a pertinent negative for us. Generally, this is caused by damage to the nerve due to swelling, which causes the dilation on that side. This is our clinical signs of Cushing's triad. Alterations in ventilatory patterns. They can breathe really fast. They can breathe really slow. They can have a period of apnea. They can breathe fast, slow. I mean, just patterns are all over the place. It's referred to as Shine-Stokes in terms of respiratory names. You can also see abnormal posturing. As you see an A there, that's decorticate posturing, when they're actually flexing towards their core. B is decerebrate posturing, where they're actually flexing outward. Generally caused by brain herniation or swelling. Bleeding is controlled. Airway is maintained with a nasal airway. Wouldn't have been my first choice. And a bag mask device. Breathing is maintained by mildly hyperventilating the patient, keeping the ventilatory rate 20 breaths per minute, watching capnography and keeping it between 30 and 35. Lungs remain clear. Blood pressure is maintained at 168/90. Patient's color improves. Pulse 56, strong and regular. Serial neurologic exams are completed. Patient has decerebrate posturing and is a GCS of 5 now. Did the patient decline, but is he being managed? He went downhill, but we're managing it. Now, if need be, we could look at intubating this patient if things get worse. One route to the hospital, you complete the secondary survey, you transport to the closest level 1. Stat CT was completed and the OR was mobilized for evacuation of a large epidural hematoma. After surgery, the patient was admitted to the trauma ICU with continuing care. We've got like 40 slides left, so we don't have a whole lot to go. I think it's this and then 2 others that make up 40 slides total. We'll buzz through this one, then I'll give you guys another break, and then we'll finish up those last 20 slides. Spinal trauma, that could kind of go hand in hand when we talk about like the guy that fell off the ladder. It could go, I mean, the guy that fell on the motorcycle, the skateboarder, all of those could potentially lean towards some sort of spinal trauma. Sunny day out, 82 degrees. Scene is what you see here. 24-year-old male, unable to move his arms or legs after diving headfirst into a backyard pool. Patient has been removed from the pool by bystanders. Scene appears safe. Bystanders pulled the patient from the pool and placed him on the pool deck. Patient is lying supine, complaining of neck pain. My main concern is a compression injury. He hit his head on the bottom of the pool. Maybe there's compression, spinal cord injury, especially with the lack of movement of extremities, and he had to be pulled out of the pool. No severe external bleeding found. Airway is open and patent. Breathing is fast with normal chest rise. Circulation slow, thready pulse. Skin is pink and warm. GCS a 10, minor abrasion to the forehead. So besides his GCS and pulse, I mean, nothing's crazy. Causes primarily MVCs like we would see with traumatic brain injuries, followed by falls, penetrating injuries, then sports injuries. I would say that majority of the ones that we come into contact with are going to be the top two. MVCs or falls. MVCs affect all different types of age groups. Falls, we're going to see it primarily in our older populations. Severity of the injury depends on the injury that is the region that is potentially injured and any damage to nearby anatomy. Primary injury, moment of initial impact. They fall, they hit something in a car accident, and then secondary could be something being thrown into them or injuries that occur after the initial injury. Here's our vital signs for our patient. Heart rate of 54, end tidal 42, blood pressure 82/50 with respirations of 20. Secondary survey, abrasion to the top of the head, pain on palpation to C5, cervical 5 and cervical 6, no deformity or crepitus noted. Abdomen is soft, untender, pelvis is stable, priapism noted. Back is unremarkable, assess with moving patient onto splitting device. Patient is unable to feel, move his arms or legs. What does it tell you almost definitively if the patient has a priapism?
They have a break in their spine somewhere.
They have a significant spinal cord injury. Immediate interventions. What are your immediate interventions based around?
C-spine.
Okay. Stabilizing the patient, so manually stabilizing them. What else?
Raises blood pressure.
Yeah, mine's maintaining perfusion, and then honestly getting him to where he needs to go, rapidly transporting him. Dermatomes they're used to assist in determining the level of injury. It's really just like a peripheral neurologic assessment where we're looking at pulse, movement, sensation, where we're asking them to squeeze our hand. We're asking if they can feel us touching them. And really, we're just looking at the loss of sensation in certain areas. From clavicles down could be a C4, C5 injury. And you can see kind of on that picture there. Nipples down, T4. And our concern with that area specifically is if it's severe enough, do they lose the ability to breathe? T10 injury, umbilicus, is there potential that this patient has no movement below the waist? And then pelvis, T12. So especially with pelvis, do they lose are they incontinent? Do they lose the ability to control when they use the bathroom? Pain in the neck or back, pain on movement of neck or back. These are just common signs and symptoms. Deformity of the spinal column. To actually get a true deformity of the spinal column, it is a pretty significant mechanism of injury. If you see decerebrate posturing, decorticate posturing, that could also indicate some sort of spinal cord injury. Our treatment should be primarily based off of the mechanism of injury. Now, how we splint them might change. Are we using a scoop stretcher? Are we just lifting them, rolling them onto a backboard? Are we using a Stokes basket? That kind of depends on the scene itself. I would say always err on the side of caution when it comes to immobilizing somebody. I know some protocols have what's called selective spinal immobilization that says, if the patient is complaining of pain or there's no indication that the patient needs to be backboarded, fine, we don't have to backboard them. Or if you think that's going to cause more injury, as opposed to we used to backboard anybody. I mean, you had any sort of trauma, you were getting backboarded. They were standing up. We would literally do a standing takedown where we put a backboard up against their back and laid them down onto it. As to where now it's kind of based off of our assessment of the patient. If they've had any sort of injury to their back, their head, any significant MOI, falls from a height, ejection from motor vehicle, any sort of compression where you're concerned about spinal cord injury. Based off the patient's GCS of 10, is he reliable to evaluate or give you information in your opinion? And what conditions would make you doubt a patient's reliability? What are things that you would see that would make you doubt what he's saying?
Repeating the
I
same
would say
thing.
Whoever was speaking first, go ahead.
Repeating the same thing over and over again.
Okay, repetitive speech. Altered mental status. Another one would be if they're under the influence of something. Drugs, alcohol. Those kind of deem the patient unreliable. I hate to say that, but and again, packaging depends on what you have. In this situation, if you're able to roll them onto a backboard, great. If it's an instance where maybe you're using a scoop stretcher, that might be what you have to do. Stokes baskets, we're going to see for more like wilderness type terrain or uneven terrain, or if we need to carry the patient for a long period of time. If the patient was unconscious, we're going to move a little bit quicker. Packaging might not be any different, but we're going to move with a little more haste. But he's not far off. I mean, GCS of 10 when he's not normally that way. Vital signs, abnormality, potentially due to a spinal cord injury, depending on where that spinal cord injury is at. Again, our treatment should be based on maintaining perfusion with the patient, addressing what other issues could be causing an altered mental status, checking a blood sugar, making sure he's not under the influence of something. This is kind of what I mentioned earlier with spinal shock versus neurogenic shock. Spinal shock is an immediate temporary loss, as to neurogenic is a sudden loss that can be prolonged. It presents pretty much the same. So there's no way for us to definitively say one versus the other. Keep our patient warm, maintain oxygenation, our reassessment vital signs, heart rate 54, blood pressure 92 or 54. Are you okay with those vital signs in a bad situation? Or would you treat those? And I'm going to ask you another question here. With a low heart rate, would you treat a patient like this with atropine? Or would you treat a trauma patient with atropine? Speed up their heart.
no.
It kind
Or
of depends on what they have, but I'm going to lean towards no as well, because what happens if that patient's bleeding internally and I give them atropine?
You're going to make them bleed more.
They're going to, I'm turning on a garden hose at that point. Absolutely. Patients transported by ground ambulance to level 1 trauma center. Patient had an incomplete spinal cord injury with excellent potential for neurologic recovery. Patient was discharged several weeks later to a rehab facility and discharged home 3 months later with almost full mobility. However, he will require further rehab over time. All right, let's take another 10-minute break, and then I should have you guys out of here by 8:30. Any questions so far? All right, take 10 minutes, and then we'll meet back here at 8:08. All right, this is actually our last lesson before we get to like the summary. So it's pretty straightforward, and we're looking at our special considerations. Now, special considerations in regards to trauma patients could be pregnant patients, it could be elderly patients, and it could be our kids. Could be somebody that's maybe in a wheelchair that experienced trauma. It's things that are really off the wall that maybe we just don't think of. And also looking at burns, you know, we can't forget that burns are also classified as trauma. In this instance, you have a 2-year-old male, 2nd-degree burns to the left hand, audible stridor. So we've got upper airway potential compromise. Skin is cool, pale, and dry. Patient was crawling on the counter, placed his hand in a pot of water that was boiling on the stove. That's all the information you have as far as dispatch goes. How common do you think burns are in PEDS patients? And what types of burns are common?
Pretty common, and like candles and or wax, water.
Things that pique kids' curiosity. They want to know everything. They know that's why we preach don't leave handles of pots and pans sticking over the stove. Don't leave objects that kids could get and they could burn themselves. And generally it's going to be their extremities, like their feet or their hands that are punching and get burned, or their face, like they get a splash burn. What would lead you to believe that maybe this was intentionally or like a case of abuse? What would make you think that?
Old wounds healing.
Okay, wounds healing into various stages. Maybe the story isn't matching up. The story isn't matching the injury pattern. Different degrees of burns. Superficial burns, which are really just at the surface, first degree. I mean, you can even see first degree sunburns. Partial thickness burns, second degree. And then full thickness, when we start to see that waxy, like tarry, and maybe the patient doesn't have any pain at that point, that's when we're looking more at the third degree burn. Primarily, the ones that we're going to see increased are going to be our extremes of age. Our really young patients are really old patients, unfortunately, because elderly people, maybe something happened on accident, and they're younger people, again, they're just very curious. Now, when it comes to adults versus children, anatomically and physiologically, they're different, right? Kids' heads take up a lot more room than adults do, and compared to their body. When you look at an adult's torso versus a kid's torso, there's difference of it. We'll get to like our rules of nines here shortly. Pediatric anatomy, again, it kind of goes back to our airway. It's a lot more floppy. It doesn't take as much pressure for the airway to close. What's our concern with Strider? What is that? What's our concern? What could cause that, I guess, in this instance? Swelling. Okay. Maybe it was an upper airway burn of some sort, maybe inhaling boiling fumes. I mean, that's the only thing I can pull from this. Most pediatric injuries don't cause immediate massive amounts of hemorrhaging. Blood pressure in kids is a poor indicator of blood loss and peripheral perfusion. That's why we generally rely off of like cap refill in our younger kids. Kids will compensate for so long, but the problem is then they just drop. They don't even go to the decompensated phase. They immediately go like irreversible signs of shock. They can compensate for so long. Think of like a roller coaster. You climb a hill and then it just drops on the other side. That's how a kid compensates when it comes to shock. Do you agree when it comes to airway wise, intubation for airway control, and why? What's your alternative if you don't intubate this kid and the airway shuts?
A crike.
Okay, now think of this. Can you crike a kid that you can't identify the landmarks? Because they don't have landmarks at that age. And that's literally one of the contraindications of a crike, an inability to identify landmarks. So you're left trying to intubate this kid with all your might. Patients placed on 100% of humidified oxygen via BVM to try and reduce some of the swelling. Elevating the burn injury, it looks like it was to the palm of the hands. And we had blistering, so that'd be like a second degree type burn. When we get blistering, we're looking second degree. Disabilities, none. Expose the patient to make sure there are no other burns. Again, is there potential there were splash burns to the front of the torso? If there's clothes that were burnt, generally we want to stop the burning process, but if clothes are like stuck to the skin, we leave those in place. Remember, the area that's burned, they lose the ability to thermoregulate at that point. We generally don't want to put them on like a cooled towel or like moisten something and put it on them, because again, they can't regulate temperature. and maybe that makes them too cold. Generally, we'll just say wrap whatever is burned in like a dry, sterile dressing just to prevent infection and to try to cover it up. But we don't wrap them in like a moist towel or anything like that. We cover them up actually the opposite. We try to make sure they can maintain temperature. Airway management, we kind of discussed that because we had the audible stridor. What physical assessment finding indicates the potential for respiratory compromise? And I mentioned that. It's the stridor itself, and that's child and adult. You hear stridor, that's always a big concern, especially how long has this been going on? Is it something I need to take immediate action with, or is it something that, you know, I'm maybe giving an EpiPen because it's a case of anaphylaxis? Get very familiar with your rules of nines. Kids and adults, I'll tell you, for adults, I use rules of 4.5. I don't use the rules of nines because it's really hard for me to memorize. So the way I look at an adult is I say, okay, the head total is a 9. So the way I say it is I go, okay, the face is 4.5, the back of the head is 4.5. Torso, right up or right chest, 4.5, left chest, 4.5, left abdomen, 4.5, right abdomen, 4.5. That gives me my 18. Arms, upper arm, 4.5, lower arm, 4.5. Or you could say front of the arm, 4.5, back of the arm, 4.5. Legs, upper, front, 4.5, upper back, 4.5. Lower front, 4.5, lower back, 4. Everything I do is in 4.5, besides like the genital area, which is always going to be 1%. It's just easier for me to know, okay, 4.5. Instead of, okay, is this 9 or is this 18? It's just a lot easier for me to memorize it. With kids, I'll be honest, it's really hard to memorize infant versus child, in my opinion. I mean, torso versus like extremities is pretty similar to adults. Heads are going to be a lot greater because kids' heads are huge in comparison to their body. So honestly, what I do is I look at the adult and I'll figure out the adult number, and then I scale it down based off of that. So if they say, you know, the front torso of a kid is burned and, we'll say one of the right legs, I figured that out what that is for an adult. And then I move it down a little bit. And that's just for testing reasons. In terms of like real life, generally we're not the best at estimating this, or we have a graph in our ambulance, but to memorize this is almost impossible. If you can memorize the adults, that's a start. What concerns you about this picture?
The burns on his chest.
Okay, burns on the chest. What else? If you notice, his upper arm doesn't match the color of the rest of his body. So that arm that we're looking at right there, and we've got blistering, I'm going to guess that's like a 3rd-degree burn or a really severe 2nd degree to where it's taken off his skin. Patient's intubated in this picture, so I'm guessing there was concern for upper airway compromise. Now, when it comes to fluid resuscitation, this is something you will have to know. It's called the Parkland-Burn formula, and it's how we estimate how much fluid to give patients in burn situations. It's the amount of fluid that should be given in 24 hours total. So the first thing we do is 4 mLs is a constant. Doesn't matter if it's a kid, doesn't matter if it's an adult. Then we take that 4 and multiply it by body weight in kilograms. Then we multiply that by the total body surface area burned. So let's just say we have a kid that weighs, or somebody that weighs 80 kilos. So I do 4 times 80, which gives me 320 times, let's just say 9%. So 320 times 9, I got to get my calculator out because I'm not good at math, gives me 2,880. The first half of that, we split it in half. 1,440 should be given in the first 8 hours. and the other 1,440 should be given in the last 16 hours. So if you're ever asked about Parkland burn formula, it's always 4 mLs times body weight in kilograms times total body surface area burned. Generally, like 9% in arm, we're not going to be too concerned about fluid resuscitation. This is more like total body burns. And there's on the way to the hospital, you are not going to give them as much fluid as they need in 8 hours. So don't get freaked out by that, but you should need to know this for testing reasons. Parkland burn formula, 4 mLs times body weight in kilograms times total body surface area burned. And again, even if you're estimating based off of the rule of nines or rule 4.5s, you'll get it close enough to how much fluid should be administered. Adults, and I kind of brought this up earlier, lactated ringers is ideal. Pediatric patients, they generally want to give them D5 just because they're burning through sugar. Now, when it comes to pain management, give them as much pain meds as you need. I mean, even if you have to sedate them, because it is a very painful event they're going through. Now, if they have total 3rd-degree burns all over their body, they might not feel pain at all. So maybe it's an instance where you're not doing pain control or you're giving them a very minimal amount. If that means you have to, look at blood pressure of the patient and choose what you're giving them, because is there a potential it's going to drop their pressure? Maybe this is the instance where ketamine is great. Most of the time you'll see fentanyl or morphine, but again, if their blood pressure is low, we have to be careful with what we're giving them because it could drop their pressure even more. Now here, let's just use Iowa as an example. Where do you think primarily this patient should get transported to? Almost all burn patients, where they get transported to.
Iowa City.
Closest burn.
The U is generally where they'll go. Methodist is a level 1 trauma center. We fly patients to the U all the time for burns. And we'll even, if somebody's coming in by helicopter, we'll even say that maybe just taking them straight to the U might be the best option because they have a long-term burn facility greater than what we have here in the metro. Secondary survey is performed during transport. No additional injuries noted. Patients transported by ambulance to a designated burn center. In this instance, like a level 1, level 2 trauma center would probably be fine. Where we're talking about like transporting somebody to the U would be, I mean, they have a lot more and it's extensive and it's going to be long-term recovery. Patient is discharged to home following several successful skin grafts. Incident was reported to CPS for follow-up. Because it is a child, there were burns to the hands, burns to the airway, which that freaks me out a little bit because nothing makes sense with that. I cannot say this enough. If you're looking at managing airway, especially in a PEDS patient, reassess them constantly. And also be reassessing all their other vital signs. I mean, continuously reassess it. Blood pressure every 5 minutes, check their pain level, reassess their temperature, look for any sort of changes. Now, elderly people, it's very similar because they lose things as they get older. They lose, brain mass. They lose renal function, the way their organs function. They lose, they develop a pain tolerance. They lose the ability to clot. They have elasticity of their skin, so their skin is very thin. Body fat. They don't regulate temperature the same. They're very much like a child. And I mean, especially when we're talking like Alzheimer's or dementia, those also have to be taken into account when we're talking about with our elderly patients. But what I tell everybody is if it's somebody that's severely or really old, treat them like you would a kid. I mean, don't like treat literally, but as far as issues you can see with them. So when we talk about, and this is just kind of bringing out everything together, focus on principles rather than preferences. Principles, what does this patient need right now? Preferences is, okay, there's different routes to get there. Focus on what that patient needs in that moment. Communicate communicate. Talk with the facility you're going to, talk with the person that's coming to help you, talk with the helicopter that's coming to help you. Ultimately, our number one rule in emergency medical services is to do no further harm. Look at the safety of yourself, look at the safety of your patient. Look at your scene and start developing things on the way to the scene. Using your X, A, B, C, D, E, looking for your massive bleeding, your airway, breathing, circulation, disability, and then exposure or environment. Is there the need for triage? Is this a mass casualty incident? Is there the need for specialized care? Identify conditions that might lead to your patient having more of a problem. Special considerations such as our pediatric patients, our OB patients, our geriatric patients, especially like when it comes to OB, know that their vital signs are different. So if we see changes that don't make sense, they normally have a heart rate that's higher. They normally have blood pressure that's a little bit higher. They normally have a glucose that's a little bit higher. Ultimately, we play a huge role in the reduction of death disabilities based off of the treatment that we administer at scenes. Our services are responsible for CQI, going through and seeing what we could do better. It's an ongoing process within your agency. But if there's things that, you run a call that you really want somebody to take a look at, you want your medical director to take a look at, by all means, ask for a review of it. Constantly be reviewing your protocols, procedures, guidelines, educating yourself, being adaptive to changes that happen. We will continually play a role in how we prevent injuries, providing education to elderly people. When it comes to, their rug in front of their door, or it comes to assisting them with taking their medications, or, taping down carpets or something like that. Keeping up on our skills, the skills that we don't deal with that often, the needle cracks, the needle decompressions. Generally, your agency does that with you. We do quarterly skills at my service. Some places do semi-annually, some places do annually, some places do biannually. Just because your service only offers so many training classes, branch out a little bit. And if there's services that offer classes around you, or there's classes that you want to attend, by all means do it, because it really increases your knowledge. And that brings us to the end of PHTLS. Are there any questions that I can answer? Or after AMLS is PHTLS pretty straightforward in your opinion? AMLS is tough. PHTLS is like bread and butter for us, to be honest. I will make this recording available. We have to finish up GEMS next week, and then that should be it for your specialty courses. Any questions? And I will also send you guys a PDF of this, just so you have and you can review it. And if you have anything further, please let me know. Otherwise, I told you to be out of here by 8:30. Have a great rest of your night, and let me know if you have any questions.
Thank you, Rudy.